Hello everyone, myself Dr. Vishwa Patel, first year radiology resident at Siyusha Medical College. Here I am presenting a case in the Case of the Week series under the guidance of Dr. Nirmala Chudasma ma'am. A 52-year-old female patient came to our department with chief complaint of right-sided swelling in mandibular region since last 1 year. There was no associated pain, difficulty in opening mouth, chewing or articulating. On X-ray, we can see there is presence of periosteal reaction with irregular margins of mandibular body on right side, which is due to aggressive bone resorption. On CT scan, there is destruction of mandibular body extending into the ramus along with the presence of an internal matrix formation and abnormal speculated periosteal reaction, which are typical indicators of osteosarcoma. Here's a CT scan image which shows an ill-defined lytic, expansile and heterogeneously hyperdense lesion of body of mandible on right side. Axial T1 and axial T2 FATSET MRI show an aggressive osteolytic lesion involving the mandibular body on right side. Marked replacement of fatty bone marrow is evident as low signal intensity on T1 weighted images and high signal intensity on T2 FATSET images. The tumor demonstrates heterogeneous signal intensity due to areas of necrosis and mineralization. There is cortical destruction with soft tissue extension which appears as an ill-defined infiltrative mass invading the adjacent structures. Surrounding inflammatory edema is visible as diffuse signal hyperintensity in T2 FATSET image affecting the nearby muscles. Contrast enhanced imaging may further reveal heterogeneous enhancement which is indicative of tumor vascularity and necrotic components within it. Osteosarcoma of the mandible is a rare primary malignant bone tumor accounting for a small proportion of craniofacial osteosarcomas. Unlike long bone osteosarcoma, mandibular involvement typically presents in an older age group, often in the 3rd to 5th decades. Patients usually present with painless or painful jaw swelling, facial asymmetry, loosening of teeth, or sensory disturbances due to inferior alveolar nerve involvement. Imaging plays a key role in diagnosis and staging. Radiographic features are variable and may be osteolytic, osteoblastic or mixed, which is most common type. Characteristic findings include ill-defined bone destruction, cortical breach and soft tissue extension. Widening of periodontal ligament space is considered as an early and important sign in jaw osteosarcoma. Periosteal reaction may be present but is usually less than compared to appendicular osteosarcoma. CT is superior in demonstrating mineralized tumor matrix, cortical destruction, and extent of bone involvement, while MRI is essential for assessing marrow infiltration, soft tissue extension, and neurovascular involvement. Compared to long bone osteosarcoma, mandibular osteosarcoma has a lower incidence of distant metastasis, and prognosis is largely dependent on complete surgical resection with clear margins. Osteosarcoma of the mandible is an uncommon but aggressive primary malignant bone tumor with distinctive clinical and imaging characteristics compared to osteosarcoma of the long bones. The diagnosis is suggested by the presence of an ill-defined destructive mandibular lesion showing a mixed lytic sclerotic pattern, cortical breach, and associated soft tissue mass. Widening of the periodontal ligament space is an important early radiographic feature in jaw osteosarcoma and when present should raise strong suspicion of malignancy. Overall imaging findings in conjunction with clinical presentation are central to establishing the diagnosis of mandibular osteosarcoma, guiding biopsy and planning definitive surgical management. Complete surgical excision with clear margins remains the most important prognostic factor and imaging plays a pivotal role in preoperative assessment, postoperative follow-up and detection of local recurrence.